and also a concise overview of the updates on its management. Okay, so if you notice in my title slide, I purposely did not put in the usual full name of fatty liver disease, and that is a non-alcoholic fatty liver disease. I'm sure is the name that you're most used to, or short, in short, NAFLD. But now there's been a very strong push to change the name to MAFLD, or metabolic dysfunction, or some to make it shorter, metabolic associated fatty liver disease, or MAFLD. So far, um, European countries as well as us in the Asia Pacific have more or less adopted this change in nomenclature as well as change in diagnosis. It's only in the US and some other parts of the world where it's not yet fully recognized and fully accepted. But I suspect that in the future, this might be the name that that we will be using moving forward. So how do our radiologists initially diagnose fatty liver disease? And this is just snapshots of ultrasound pictures showing you the liver in the topmost part of of this slide. You can see that this is the liver compared to the right kidney. And this is usually what radiologists do in order to compare whether the liver is more echogenic than usual or not. So in patients with fatty liver disease, what happens to the liver is that it becomes more echogenic, so hyperechoic siya. So, and it's always compared to the color of your kidney. And you can see here that the kidney is usually the same echogenicity as your liver. And you can see that the liver in this part of the picture has mildly echogenic picture compared to the kidney. So in these cases, the radiologist will say that this patient has mild fatty liver. Compared to this one on the rightmost portion, you can see that the liver is markedly echogenic compared to your kidney, and the radiologist will now usually term this as severe fatty liver. Other things that they look at is, of course, the blood vessels. So here you can still see the blood vessels as well as the diaphragm. But here, in this case of severe fatty liver, you can see that it's very hard to distinguish the normal intrahepatic blood vessels, and you cannot see the diaphragm clearly anymore in patients with severe fatty liver. Now, of course, these are well and good. These are good ways for our radiologists to grade fatty liver into mild, moderate, severe. However, it's not regulated. I mean, it's not well regulated because it's affected also by the quality of your machine and sometimes the quality of the reader as well. So even though you will see sometimes in your ultrasound reports mild, moderate, or severe fatty liver, sometimes I take it with a grain of salt because it's not very, very accurate, not very, very reproducible as well. So for fatty liver disease, this is the old criteria. This is the non-alcoholic fatty liver disease diagnostic criteria. And right off the bat, you can see here that there's something that really strikes out in the diagnostic criteria. And these are the red, the ones that are shown in red. If you notice, it's sort of like a diagnosis of exclusion. Because once you diagnose fatty liver either on imaging using your ultrasound or CT or MRI, or you did a biopsy, or sometimes there are special serum biomarkers such as a fatty liver index that can detect fat in the liver. Once you have that, then you have to rule out other causes of chronic liver diseases. And that will include your hepatitis B, hepatitis C, autoimmune hepatitis. You have to rule out other causes as well of fatty liver disease, such as Wilson's disease, some medications, as well as alcohol intake. Now, this old definition, I think, is very useful, especially if you're going to do a study on patients with fatty liver disease, because you're essentially ruling out other possible causes of liver damage. And therefore, if you're doing a therapeutic trial, then you'll be more sure that the results that you get is because of your drugs and not because you were able to resolve, let's say, your hepatitis B or your autoimmune hepatitis. Okay. Now, the problem with this old criteria, however, is that we also see in the real world, you see patients with multiple chronic liver diseases. What do I mean by this? You can have a patient with chronic hepatitis B who comes in your clinic with fatty liver on ultrasound, and when you weigh the patient is overweight with high cholesterol levels. So all of the risk factors of fatty liver disease are there. So in those cases, how are you now going to say that, okay, this patient only has chronic hepatitis B and not fatty liver disease? Because it will not fit your criteria, right? So there's an inherent problem with this sort of like a diagnosis of exclusion, is that in the real world, you can have patients with multiple chronic liver diseases that will cause liver injury to your patient. And that is why it started last year when an international consortium talk about possibly changing the nomenclature and possibly changing the diagnostic criteria as well. So what they came up with is this diagnostic criteria of MAFLD, or metabolic associated fatty liver disease. Again, you need fatty liver either on biopsy or imaging or serum biomarker. Once you have that, now it's not a diagnosis of exclusion anymore, but rather a diagnosis of inclusion. So if you can see here, you have to have at least one of the following. Either you have type 2 diabetes or overweightedness or evidence of metabolic dysregulation. So if you have at least one of these risk factors, then you have already clinched your diagnosis. If you notice, it did not include excluding other causes of chronic liver disease anymore. And I think this is more practical and more realistic because we do see patients with multiple chronic liver diseases. Now, when we looked at our patients with fatty liver disease, if you notice in the MAFLD diagnostic criteria, one of the diagnostic criteria is that the patient has to be overweight. But we also have seen patients who are not overweight, not obese, but with fatty liver disease. And this is in the older literature, it's termed lean NAFLD. So meaning they're not overweight. And we've looked at our cross-sectional view of our patients with fatty liver disease. And what we've found is that lean NAFLD occurs in about 12% of our population, in our fatty liver population. And what we did notice is that lean NAFLD patients are usually younger, and they have less probability of having evidence of metabolic dysregulation. Okay, so lower metabolic syndrome, lower incidence of diabetes mellitus compared to non-lean individuals. But what do you notice? Even though it's lower, it's still present in about 30% of patients with lean NAFLD. And that is why if you look back to the diagnostic criteria for MAFLD, it's important not only to see if there's overweightedness, even if you don't get this, if you have type 2 diabetes or evidence of metabolic dysregulation, then you've already clinched the diagnosis. Now, because of this change in diagnostic criteria, it's expected that the epidemiology of fatty liver disease will also change. So when I looked at that same data set and tried to look at whether it will change the epidemiology or not, it did change it. You can see here that patients who meet both NAFLD and MAFLD comprises about 78%, and those patients who meet MAFLD criteria but not NAFLD criteria meaning these are patients usually with concomitant hepatitis B, and that is why they're out of the NAFLD criteria. About 14% and about 8% will not meet MAFLD criteria, meaning there's no metabolic dysregulation or overweightedness, but they have fatty liver disease, about 8%. And what you notice is that if you have evidence of MAFLD, then your probability of having abnormal ALT is also higher compared to those who do not meet the metabolic criteria. And that will be important later on as I discuss the risk factors for progression for patients with fatty liver disease. Now, it used to be that when you think about fatty liver disease, we used to think that it's a very innocuous disease. People won't die of fatty liver disease. They'll probably die of something else. And in a way, it's true, because most patients with fatty liver disease, they die of cardiovascular disease or cerebral vascular disease. But a good proportion of them also die of liver disease. In fact, in the States, the most common etiology for liver transplant nowadays is already fatty liver disease and not hepatitis C anymore. Okay, so how does fatty liver disease cause liver injury? Now, the way to imagine it is that for the liver, it's very much like our skin. When you have an injury, your skin will form scar tissue. The same thing happens with your liver. If you have injury into your liver, then fibrosis happens, or scar tissue formation. Okay, so before fibrosis happens, what happens first is that the patient develops simple steatosis first, meaning there's fat formation in the liver because because of the triglyceride accumulation in the liver. And then once the fat accumulates in the liver, then the patient may undergo inflammation. And that is what we now term as steatohepatitis. Now, the problem, of course, is that if this is a chronic disease, chronic problem, then your fibrosis will keep on, becoming deposited in the liver on top of each other. And finally, you will now have cirrhosis. And of course, in some patients, you can also have hepatocellular carcinoma formation. Now, how soon does this happen in your patients with fatty liver disease? In most studies, they will say that for simple steatosis to proceed to steatohepatitis, about 40 to 60% of patients will do that. And then when you look at simple steatosis going to fibrosis, meaning they will accumulate fibrosis, then that will be around 40% for all patients. For steatohepatitis, it's also about 40%. But the main difference really is the speed of progression. You can see here that for steatohepatitis, the progression by one stage of fibrosis, it's one stage every 7 years, while it's one stage every 14 years for simple steatosis. Okay, so even though when you look at the data, the probability is almost the same over time, the speed of progression is different. It's faster in patients with inflammation. And in a way, it really makes sense because as I mentioned, you need inflammation for fibrosis to be deposited into your liver. Now, a frightening 20% of patients with fatty liver disease may be what we term as rapid progressors, meaning from stage 0, no fibrosis at all, progressing to cirrhosis or bridging fibrosis in as little as 6 years. And what they found in this study is that those who are rapid progressors are more likely to have multiple risk factors, meaning they're either diabetic, with overweightedness, or with hypercholesterolemia. So the more risk factors that you have, the greater the chance of progression. Now, HCC, what about HCC? In hepatocellular carcinoma formation, it used to be that we thought that only patients with cirrhosis will develop HCC. But now we know that it's not true. Even patients without cirrhosis can develop HCC. Um, in some studies, it's as much as 50% of patients with HCC because of fatty liver disease. When they did the liver biopsy, they did not find any cirrhosis. Okay, so I think the reason why it happens is that in patients with chronic inflammation, usually the DNA damages that happen in the process of liver regeneration with the inflammation is these DNA damages are not caught and destroyed by your immune system, and that is why these DNA damages accumulates and finally leads to HCC formation. Now, we've already discussed the sort of the spectrum of fatty liver disease. Now, this slide just emphasizes to you that even though most of our patients, when you see them and diagnose them with fatty liver initially in the clinic, will not have complications yet, close to 10% will already have either HCC or cirrhosis the first time that they had the diagnosis of fatty liver disease. So the crux of this slide is that most patients with chronic liver disease because of fatty liver will not have symptoms. It's only when they have symptoms because of cirrhosis or HCC, that's the only time that they look and see a physician. So sometimes it's already too late by the time that they were diagnosed first to have fatty liver disease. And that is why it's very important to really catch patients, diagnose patients at the earlier stage, okay? Now, this study is just to emphasize that among the predictors of survival, the most important predictor is really fibrosis. So in this trial, you can see that when they looked at patients without significant fibrosis, there was no difference between steatohepatitis and simple steatosis. So the level of inflammation, even though there was numerical difference, did not really matter. However, when you look at patients with significant fibrosis, it was significantly, the survival was significantly poorer compared to those patients without significant fibrosis. Okay, so fibrosis is very important. And the reason why I'm harping on the fibrosis is that later on, I'll show you a slide where you can actually estimate the level of fibrosis in your patients with fatty liver disease right there in your clinic. Okay, now this is just a slide to show you that most of the guidelines really are sort of congruent in terms of advising us who are the patients who are more likely to progress, more likely to have advanced fibrosis. And both the American guidelines and EASL guidelines will tell you that the greater number of metabolic problems that the patient has, the greater the risk of progressive liver disease. And more importantly, as I've mentioned earlier, it's very important to diagnose earlier. And if you have a patient with type 2 diabetes, or a patient who's obese, or has dyslipidemia, or with a metabolic syndrome or PCOS, then these patients need to be screened for fatty liver disease and worked up for liver dysfunction, as well as check for the level of fibrosis. Now, this is the bedside sort of bedside scoring system that you can actually do in your patients with fatty liver disease. And the most frequently used are the FIB-4 score and the NAFLD fibrosis score. Why is it easy to use? You can see here that for the FIB-4 score, you just need the age, ALT, AST, and platelet count. While for the NAFLD fibrosis score, you just add the BMI, albumin, and whether the patient has diabetes or not. And the good thing about this is that right there in your clinic, you can download an app that can compute the risk of fibrosis for you. Of course, there are other ways of computing for the liver fibrosis non-invasively, and that will be your FibroScan, where you can actually also do CAP, which is a controlled attenuation parameter where you can estimate the degree of liver fibrosis in the degree of fatty liver in the patient aside from the liver fibrosis. So all of these scores, non-invasive tests, are very useful because right there in your clinic, you can actually advise your patient already whether they need, more aggressive treatment or not. So, which brings us to MAFLD or NAFLD treatment. So I will just jump around between MAFLD and NAFLD because some of the older studies were still using NAFLD as the terminology. Now, for the FDA, they've shown us that if you're going to do a study for fatty liver disease, then these are the two important endpoints. One is resolution of the steatohepatitis or resolution of the inflammation in the liver. And then the next one is going to be fibrosis improvement. And mind you, these two endpoints are not exclusive of each other because most of the time, before you are able to resolve the fibrosis, it's important for you to resolve the inflammation first in the liver. Okay, so hepatitis resolution is also very important, as shown in this study, where they looked at before and after biopsies and whether improvement of the spectrum of the fatty liver would improve the fibrosis scores as well. So you can see here that for patients who initially had NASH, that improved to fatty liver disease, to simple steatosis on the next biopsy. You can see that the probability of having significant fibrosis decreased from about 25% initially to only about 15% when the patients improve. Same thing when you have NASH to borderline scores, you will see that the degree of significant fibrosis also decreased in number. So this trial just proves to us that if you improve the liver inflammation, then you will also eventually improve your liver fibrosis scores. And what they found that were independently predictive of fibrosis regression is that when you improve your steatosis, your fat in the liver, you improve your lobular inflammation and decrease your ballooning degeneration, then the probability of fibrosis regression is also increased. Okay, so this next slide is just, I'm not going to ask you to read through everything here, but this is just to show you that the previous hypothesis for the pathophysiology of fatty liver disease was the two-hit hypothesis, meaning first hit you have steatosis, second hit you have oxidation damage. That's it. But nowadays we now have what we call the multi-hit hypothesis, and you can see here that there's a lot of pathways where patients can develop fatty liver disease, but the final common pathway is still oxidation damage inside the liver. Okay, now because of this multi-hit hypothesis, there has been several drugs that have been in the pipeline, and they've tried to look at whether these drugs will have an effect on fatty liver disease. Obeticholic acid is the one that's further along in terms of trial, but it has not been approved by the FDA yet because of the increased risk of pruritus and not a lot of not very strong therapeutic results so far in the phase 3 trials. Now the other drugs, elafibranor, selonsertib, and cenicriviroc, unfortunately, the phase 3 trials have come out and it has been shown to be not effective for patients with fatty liver disease. So we won't see them, I guess, in the present form and dosage for fatty liver disease. Now, the three drugs that are available to us and that has been shown in trials to be have an effect on fatty liver disease are pioglitazone, vitamin E, and UDCA. Importantly, you can see that both vitamin E and ursodeoxycholic acid acts in the final, sort of the final common pathway of fatty liver disease injury, and that is in the oxidation damage part. Now, of course, with all those drugs that I've shown you, the most important part of treatment is still diet and exercise. You still have to make sure that the patient do diet and do exercise on their own. Even in patients who are lean, it's important for them to have exercise. And there are a few studies that have shown that even if you're lean, there's still some improvement in the liver histology, even if you lose a little bit of weight, even if you're lean. Now, this is what happens when you have this degree of weight loss, and what happens to the liver, and how easy or how hard it is to sustain it. And you can see that the greater the weight loss that you achieve, the greater the improvement in the liver histology, but the harder it is to sustain the weight loss. Of course, most guidelines will say that you have to have at least 5% weight loss in your patients in order to have an effect. Now, do our patients follow our advice? Unfortunately, you can see in this slide, the answer is no. Only about 40% will lose weight, and a full third of our patients, or my patients, will actually gain weight instead of lose weight. So very hard-headed in most patients. And when we try to follow up these patients and try to see if maybe over time will they follow my advice of losing weight, you can see that among those patients who had weight loss after the first year, at the end of 7 years, only 64% maintained that weight loss, and about a third gained weight. Okay, so very hard to convince them to stay true to what they initially lost in the first year. Now, this is more alarming. Those patients who had gained weight after the first year, 100% of them has a weight gain at the end of 7 years. So, which brings us to pharmacotherapy. As I've mentioned, even though weight loss is the cornerstone treatment, you still need pharmacotherapy in most cases because most of our patients are really not very compliant. So for UDCA, the way it acts on fatty liver disease is that because it's an hydrophilic bile acid, it will replace your hydrophobic bile acids, and in the process, it will reduce your oxidative stress and reduce your apoptosis. It will also stabilize your hepatocyte cell membrane, and it also has some metabolic effects by lowering your hyperglycemia and improves your insulin resistance. So the earliest study on UDCA was unfortunately a negative study. So this is the first study, RCT, placebo-controlled, and you can see that at the dose of 12 to 15 milligram per kilogram per day, although there was improvement in the inflammation as well as in fibrosis, in patients who were given UDCA, it was no different when compared to placebo. Okay, now this is common actually in patients in fatty liver studies because there's a very strong placebo effect in fatty liver disease. So therefore, because of the negative study, this next set of investigators thought that maybe the first study was underdosed. So they tried to do another study using a higher dose of your UDCA, 23 to 28 milligram per kilogram per day. Again, biopsy-proven NASH patients given for 1.5 years, placebo-controlled. And they look at weight changes during treatment to make sure that weight changes did not affect or influence the results of their study. And you can see that for both UDCA and placebo groups, there was really no difference in terms of weight changes between the two groups. So the weight changes did not affect the results of the study. So when they look at biochemical parameters, you can see that ALT and AST was, although it decreased in your UDCA, it was no different when compared to placebo. However, when you look at GGT levels, GGT, by the way, has been shown in one study to be a significant predictor of survival in patients with fatty liver disease. You can see here that GGT levels were significantly lower in patients who were given UDCA compared to placebo. More importantly, when they looked at biopsy results, you can see that for liver lobular inflammation, there was a significant decrease in your lobular inflammation in the UDCA group compared to your placebo. Okay, no difference in fibrosis scores yet, because I think you need a longer duration of treatment in order to have an effect on fibrosis. Now, this next study looked at an even higher dose of UDCA, 28 to 35 milligram per kilogram per day. Again, biopsy-proven NASH, gave the UDCA versus placebo for 1 year. They looked at physical activity as a surrogate marker of whether the patient will have weight changes during the study. And again, there was no difference between UDCA and placebo group. So the endpoint here is not a histologic endpoint, but rather using a non-invasive way of testing the fibrosis, and that is the fibro test. And you can see that in this study, biochemically, using a higher dose of your UDCA, both the ALT and AST and GGT levels were significantly improved compared to your placebo group when you give UDCA. Now, also important is that there was a significant change in the fibro test results, significant decrease in the UDCA group compared to increases in your placebo group. Now, I will skip this in the interest of time. Now, you might ask that, what if I don't want to give higher dose of UDCA? Can I give a lower dose of UDCA? This next study tries to answer that question. So this is a 3-arm study, UDCA alone versus UDCA plus vitamin E versus placebo. And you can see that for both ALT and AST, although there was a numerical difference between your UDCA alone group, shown in gray, versus placebo, only the combination group showed a significant difference compared to your placebo group. So both ALT and AST, the combination group was better, although there was a numerical difference already comparing your UDCA alone versus placebo. Okay, and importantly, again, when they looked at histology, there was a significant difference between the combination group compared to your placebo in terms of the activity index, which reflects your inflammation. So in summary, I've shown you that both simple steatosis and steatohepatitis can progress to liver cirrhosis and HCC. And that is why we really need to be vigilant and follow these patients up. And it's important to get the liver fibrosis because fibrosis is the single most important prognostic factor for survival. And then resolution of inflammatory activity and regression of fibrosis are very important goals of treatment. And that is why we need to follow these patients up, especially your ALT levels, as well as your non-invasive tests for liver fibrosis. Diet and exercise, I've shown you, are very important cornerstones of treatment, but very hard to achieve. And if you're going to give UDCA alone, then it's better to give it at a higher dose, 23 to 35 milligram per kilogram per day. But if you're going to give it at the lower dose at 12 to 15 milligram per kilogram per day, then I suggest you give it with vitamin E because it will improve your histologic and biochemical parameters. And with that, I will leave you with this slide, and hopefully your patients will do more exercise than this one. And good day. Thank you very much.
Okay. Thank you, Dr. Wong, for that concise yet study-based presentation on MAFOLD. Indeed, it is very liberating when you highlighted the spectrum of MAFOLD from the changes in the diagnostic criteria of fatty liver to the workup to the progression of fatty liver disease from steatosis to fibrosis, cirrhosis, and to some cases to hepatocellular carcinoma. It is also stressed in the talk of Dr. Wong, um, the management using the multi-hit hypothesis, stressing on the role of weight loss and exercise and pharmacologic management with high dose UDCA. The virtual floor is now open for your questions, or you may type them down in the chat box. Hi, Dr. Wong.
Hello, Dr.
Okay, I
Hilario.
have
Thank you for having me.
actually madami po tayong questions right now. So I will
Yeah,
start
I saw the
with
chat box.
for patient diagnosed to have muffled, is radiographic monitoring recommended? And how often do we repeat ultrasound?
Yeah, thank you for the question. And you will see it often actually in practice, where if you have a patient with fatty liver on ultrasound, you will have a repeat ultrasound after a few years, after a few months even. The problem with doing that is that even for successful pharmacologic trials, you will see very few patients actually with improvement in the radiologic findings of fatty liver on ultrasound. And there are several reasons for this. One is the grading of the amount of fat on ultrasound is not really well regulated or well defined. Oh, did I? Is my internet connection okay? Okay, naman. Okay, sige. Yeah. So it's not very well defined, so that sometimes you will get a diagnosis of moderate fatty liver, and next time you will have severe fatty liver, but it's really not based on actual objective findings. So in general, what I do with my patients is that I will get an ultrasound every year at least. But maybe in patients with underlying cirrhosis, then you will have to do surveillance for HCC. Then you would have to do your ultrasound every 6 months in patients with cirrhosis, based on your non-invasive test.
Okay, Dr. Wong, thank you for that answer. Okay, another question is, what is the benefit or the role of transient elastography over other diagnostic workups for muffled?
Yes. Well, I mentioned in my lecture that you need to evaluate patients for fibrosis, because fibrosis is still the most important predictor of survival in patients with fatty liver. And one of the things that you can do is transient elastography or fibroscan, and that will give you a good idea of the amount of fibrosis that has already happened in the patient. Other tests that you can do, there's a fibro test, which is you cannot compute it on your own, but there are other non-invasive tests that you can compute on your own, like your APRI or your AST over platelet ratio, your FIB-4 score, your NAFLD fibrosis scores. All of these, you can just plug it into your smartphone. MedCalc is usually what I use for that. And it will give you numbers and give you an estimate of the amount of fibrosis. So compared to other tests, FibroScan looks at a different aspect of the disease, and that is looking at fibrosis. While if you look at, let's say, albumin, your prothrombin time, your platelet count, those are reflections of your liver function. So therefore, if you have liver cirrhosis already, sometimes the liver function deteriorates and your albumin will go down, your prothrombin time will be prolonged, and then, of course, you have your liver enzymes, your ALP, AST. Those are good markers of liver inflammation. However, having said that, there are also studies that show that even if you have normal ALP, normal AST, it doesn't mean that you don't have significant fibrosis. So you still have to evaluate for fibrosis.
Okay, another question, Dr. Wong, is what is the role of hepatoprotectants basically in fatty liver disease?
Yeah, that's a broad question actually, because when you say hepatoprotectants, there are a lot out there that are being marketed. Depending on how you look at it, ursodeoxycholic acid may be viewed as a hepatoprotectant because there's in terms of really identifying its exact role in fatty liver, it's surmised that it acts on the oxidation damage that happens. Um, so other hepatoprotectants like silimarin, your essential phospholipids, your carnitine, in terms of the level of evidence, your ursodeoxycholic acid will have the greatest amount of evidence in terms of looking at how it will affect your fatty liver disease. And I presented to you the evidence, the underlying evidence that supports the use of ursodeoxycholic acid. The other hepatoprotectants, the level of evidence are much lower compared to your UDCA.
Okay, thank you, sir. Another question is that is related with UDCA is what is the ideal dose of UDCA with vitamin E? You mentioned, sir, in your lecture the high dose of UDCA.
Yeah, if you combine it with vitamin E, then you can give it at a lower dose, 12 to 15 milligram per kilogram per day. So if you have a 50 kilogram person, then you will need about 600 a day. So that's about 2 tablets of your ursodeoxycholic acid, your Ursomax, for fatty liver. If you combine it with vitamin E. And
So,
vitamin
okay.
E usually given at 400 BID.
So okay, so that's 2 tabs, 300 milligrams UDCA plus 2 capsules of vitamin A, 400 IU. Okay, sir. Another question that we have is okay, it was already mentioned in your lecture the how long do we expect for patients diagnosed to have muffled to have a cirrhotic liver? Okay, this was already answered by Dr. Wong. Okay, another question is the role of silimarine, as Dr. Wong mentioned, the hepatoprotectants over muffled and NAFLD. Okay. Okay, another question, Dr. Wong, is for those patients with findings of focal fat sparing in their liver ultrasound, will there be a difference in monitoring or further testing?
Yeah, there should be no difference in terms of how you monitor these patients. But one thing that you have to be aware of is that the reason why there's focal fat sparing is sometimes not the entire liver will be involved if you have fat in the liver. So there will be some areas that will have less fat, and that will appear a little hypoechoic compared to your hyperechoic fatty liver. And you have to be aware where it's located usually and how it looks like. So focal fat sparing usually will be around the very close to the gallbladder, very close to the edges of the liver, and usually it's they term it as geographic. So hindi siya yung bilog na nodular na hypoechoic. So the reason why I mentioned that is that you have to be careful whenever you have a reading of focal fat sparing. Ideally, you look at the film, see how it appears like, because if it appears like it's nodular, like it's really circular, ovoid, then maybe you have to evaluate for a real lesion in the liver. You might need to do a triphasic scan, either CT or MRI, just to make sure that it's not HCC.
Okay, thank you, sir. So another question is how long do we maintain patients on UDCA?
Yes, very relevant and practical question. If you base it on the studies, the longest study was 2 years for UDCA. However, as with all, drug studies, there's a limit in terms of spending for the study. So you cannot, do a 10-year study. So therefore, they will limit it to a certain year and look at the endpoints at that year. So if you just base it on the study, 2 years. But then in practical terms, in your patients, then you treat until you achieve your goal. So if your goal, for example, at the outset is to decrease the liver inflammation, then the most accurate or maybe an indirect reflection of your inflammation will be ALT. If your ALT normalizes, then you have achieve inflammation resolution, and then maybe you can stop at that time. But then if you have baseline cirrhosis or baseline um, advanced fibrosis, then I would be very careful in stopping any pharmacotherapy that is effective for the patient. I would probably treat them for life if they have cirrhosis.
Okay. So another related question is, what is a better modality or diagnostic workup in monitoring patients with fatty liver? Is it radiologic findings or liver enzyme studies?
Yeah, well, for fatty liver, for diagnosis, it's really, usually ultrasound first to diagnose it. And then biochemical laboratory studies, then usually you look for risk factors at the outset, at the baseline. So you check for cholesterol, triglycerides, your sugar levels. You check for liver enzymes, your ALT, AST. You check for liver function tests, and that will include your albumin, your prothrombin time, and your platelet count. So basically, that's the initial workup. And then I've mentioned also that you need to check for the level of fibrosis. So either you compute for the FIB4 score, NAFLD fibrosis score. If you don't have FibroScan available in your area, then you do those things. If FibroScan is available, then you also do FibroScan in order for you to have a little bit more data in terms of what the patient has. And then of course depends on the fibrosis scores. That will determine how often you will monitor patients. If patient is cirrhotic or advanced fibrosis, then I would monitor them every 6 months at least.
Okay, noted on that, sir. So another question is, for patients diagnosed with muffled with only slight elevations of ALT, I guess less than 3 times, and maintained on statins, should we discontinue statins or wait for liver enzymes to be 3 times elevated prior to stopping it?
Yeah, that is a very relevant question also, and we often see that question from our cardiologist friends. And if you look at all the studies on statins, all the big studies on statins, you will see that the elevation in ALT levels are actually quite transient. So it will increase a little bit, and then once you have resolved the hypercholesterolemia, which is a risk factor for fatty liver, then the fatty liver also improves. Your liver inflammation also improves. So in most studies that look at specifically ALT, your statins, and what its effects are on fatty liver, most of the studies will say there's biochemical improvement in those patients. So for me, if you have a patient with elevation in ALT on statins, I would just continue the statins because I want to decrease one of the risk factors that the patient has for fatty liver. And then diet and exercise. I mean, I always tell my patients, no amount of pharmacotherapy will help you if you don't lose weight. But you can see that in my data, patients do not really, follow the advice. It's very difficult. I don't know how to solve it.
Okay, sir. So since you mentioned that cornerstone still for management of muffled is exercise and weight loss, one of the questions here is, how do we motivate patients on lifestyle modification? Was it mentioned in in one of the studies, or?
I don't know. I guess one of the main, I think one of the main important things that you have to do is you have to set a good example. You cannot be overweight or obese and then tell your patients to lose weight. That alone, you lose a lot of credibility already. But you can see that I'm not overweight. Maybe if you compute my BMI, a little overweight, but not obese. But even then, I cannot convince my patients to lose weight. I saw in the chat box somewhere that the question was asked. So how do you convince patients then? If you look at studies, most of the studies where weight loss was successful was if you have a structured program for weight loss, meaning these patients are required to attend maybe every 2 weeks, attend that session, and then there's a specific person really monitoring their weight and what they're doing at home and all that. Those programs are very successful. But in the real world, who has time for it? Who has the finances or or logistics for it?
Okay. Again, thank you, Dr. Wong, for that very again liberating talk on muffled. I guess if you have any more questions, you may type in down in the chat box, and Dr. Wong will be gracious enough to answer them. So I now give you Regine and MJ.
That was such an enlightening, informative lecture. Thank you, Dr. Wong, for the lecture, and Dr. Hilario for moderating. May we request Dr. Wong to please stay on cam as we award to you the Certificate of Appreciation, which reads, Hospital ng Maynila Medical Center, Department of